you, and I'm glad to be here. I'm excited to talk about this topic with people who are on the front lines and trying to pull the needle out of the haystack that is AFM. We'll start. I don't have any relevant disclosures. I think you have my objectives written out for this talk. So we'll start talking a little bit of an overview. AFM is or acute flaccid myelitis is the most common and most commonly accepted term for this condition at this point in time, but it has definitely been called a lot of different things, especially in 2014 and before that. So particularly acute flaccid paralysis, which is somewhat interchangeable with the AFM, and polio-like myelitis are terms that you may hear, but AFM is sort of the most common at this point. So here I've just listed out some of our kind of how my experience and local experience has evolved with AFM. So we noted a small cluster of AFM cases in 2008, about 5 or 6, but at the time it didn't get a lot of attention. And then in 2014, the fall, is when it really got a lot of national attention, was in the media, and recognized in the wake of an enterovirus D68 outbreak, based primarily in Colorado. And so we saw around 8 patients that year, and about 120 met the CDC definition and are among the publications that are out there. And then again, this last fall in 2016, there was another national outbreak where we've seen at least 11 patients now as part of that outbreak, and it seems to be as big or bigger than the 2014. And this is just a graph you can find on the CDC website reflecting that trend. I don't know what that sound is. Is it? I feel like is there a really annoying after sound that's bothering you guys? Am I too close or can you hear me? You can't hear me. Okay, is that better? Yes, okay. I'll stick close. So this is a graph showing the same trend. That there was a big cluster, particularly in September 2014, and again in 2016 in September. So it tends to be a fall outbreak or a fall occurrence, but there are a smattering in the intervening months. So we'll talk just through a couple of cases to give you a sense of the spectrum of how this can present and how it can evolve over time. So case 1's a girl I saw this past week in follow-up. She's a 12-year-old who had symptoms consistent with a viral illness, vomiting on day 1, got a little bit better, but then started complaining of vomiting, sore throat, had a low-grade fever, and difficulty swallowing around day 3 to 4. She saw her pediatrician, her rapid strep was negative, she'd had some congestion, went home, and then about day 6, they took her back to the ER for ongoing symptoms, and they noticed that she had oxygen desaturations, X-ray showed atelectasis, and admitted her to the ICU with primarily concerns for an infectious etiology, more of a lung process or something. But shortly after admission, she clearly had some dysarthria and developed right arm and bilateral facial weakness. And this was the MRI that was prompted by her new neurologic signs. So it's subtle, but you can see, hopefully, I don't know if the lighting's great, there's some subtle T2 hyperintensity in the brainstem, and then again here in the spinal cord. And most important is seeing over here that in the spinal cord, it's really a gray matter, even hemichord predominant lesion in this same cervical region. She was initially diagnosed with ADEM, although a whole separate talk about how she doesn't meet diagnostic criteria for that, and treated initially as infection with antibiotics, and then once they had this MRI findings, got steroids, 2 courses. The first course was given concurrently with IVIG. She required a lot of support, so she was on TPN, she had an NG tube for inability to swallow, and she got inpatient rehab and has needed ongoing outpatient rehab, including PT, OT, feeding therapy, psychotherapy, and she tried this thing called VitalStim, which is electrical stimulation of the pharyngeal muscles, trying to increase the strength of those muscles given her ongoing dysphagia. And so she has had gradual improvements over the past 6-7 months, improving weakness and improving ability to swallow. She can eat, but she still has to be very careful how she eats. If she's eating anything that's chewy, she has to take sips after every little bite. They have to be very cautious. She's got very significant shoulder weakness on the right still, and ongoing, pretty evident left facial paralysis. And you can hear, you can hear the dysarthria when she speaks as well. Case 2 is a boy from 2 years ago. He was, now he's a little older, a 3-year-old boy, previously essentially healthy, who had typical routine vaccinations in the right delt a couple weeks prior to presentation. And then he had a 5-day febrile URI, had a wheeze requiring albuterol, which wasn't typical for him, and then had presented on day 1 of onset. His mom's a neurologist and a friend of mine, actually. And so day 1, she noticed that he was eating dinner like this. He couldn't get his arm up, so he was like stooping down and feeding himself without using his deltoid. So he had also complained of things like headache, neck pain, pain in that arm, and some leg pain as well. I don't think I gave you an exam on the next page. So on examination, had clear deltoid weakness as well as severe neck weakness, to the point if you touched his head, it would just loll. He had really no neck control early on, and hyporeflexia. This is his initial MRI. Actually, I think it's the only MRI we got on him. He had some brainstem involvement, a little bit of cerebellar involvement, and a cervical lesion. Looks not complete, definitely there, not super evident here, but if you were on the radiologist screen, it's definitely abnormal. And it really extended the length of his entire cord. So you can't see his thoracic cord well on this exact slice, but you can see the lumbar and the cervical involvement. And again, this gray matter predominant H of a lesion that really is affecting more the gray matter than the white matter of the spinal cord, which is somewhat unique to this condition. And we'll talk more about the MRI pattern as we go. So his CSF, he had inflammatory CSF. The other one I didn't present, but hers was pretty bland. She only had like 6 white blood cells and everything else was normal. He had 102 whites with predominantly lymphs, but a good number of neutrophils and monocytes, which is atypical for most of our inflammatory myelitis. He had an otherwise normal CSF, and ultimately, looking back, had a stool culture growing adenovirus, but no other infectious agents identified, which is what we're finding commonly. He was hospitalized inpatient for several weeks and then a month of rehab. His hospital course was not easy. He remained febrile and continued to progress for about 4 days. He started IVIG, a good dose very early, 1 to 2 on day 1 and 2, and ultimately ended up with weakness of all 4 limbs, although in an asymmetric pattern. I mentioned his neck, and then decompensated to the point of needing BiPAP and a higher level of support in the hospital. We, at that point, really didn't know the etiology, although knew this was most consistent with AFM, so he did end up ultimately getting plasma exchange and then steroids plus this off-label compassionate use Pacapavir antiviral. He needed some gabapentin for pain, which does seem to help these kids, an NG tube, and he also had some hypertension, which is something that isn't necessarily published, but increasingly recognized in some of our patients, some of these vital sign changes. He went to rehab for a month, and he did recover significantly. It was, with all 4 limbs, he couldn't walk when he went in, and he walked out of rehab. But even now, several years out, he has really no movement of that left shoulder and ongoing weakness in his neck. But otherwise is breathing on his own, is running and moving the other limb very well. We're going to skip over case 3 in the interest of time, because I want to get to some of what we've learned and other things to think about when you're seeing kids where there's any sort of motor or limb function concern, swallowing concern, cranial nerve concern in the setting of an infection. So In 2014, we saw these as initial misdiagnoses. A couple of our kids had come in with a diagnosis of toxic synovitis of the hip as the initial diagnosis, which, a little bit of difficulty walking in the setting of a viral illness, not surprising. And then one really presented very similar to Guillain-Barré syndrome, and it was only the asymmetry and then ultimately her MRI pattern and evolution that sort of told us that this, in fact, in retrospect, was AFM. So the CDC definition is extremely broad, in my opinion. It's a kind of catch-all, which in a way is good. They're trying to figure out what is this, and but it also excludes some things. So early on they had age exclusions, which ultimately it does seem like it can affect adults even, and very young children. So they call a confirmed case acute onset of focal limb weakness plus an MRI with gray matter predominant lesion. A probable case is one with acute flaccid weakness along with CSF inflammation without necessarily meeting that MRI criteria. But again, the caveat is I don't think we completely understand the full spectrum. They're trying to figure this disease out, what is it, and give it a somewhat of a tight definition, and then kind of see what pans out. We've seen patients with no weakness, no cranial nerve findings, but cerebellar findings who have an MRI who look just like this the same week as other patients are presenting, for example. So my gut is that it's a very broad, it can cause a broad presentation, but for now, that's what they are using, and those are the cases that they want reported and want to know about. So this is some of the reports that came out of the 2014 outbreak. This is just a map showing all of the cases. You can see Colorado had the most, about 10 cases here. Well, I shouldn't say that. California had the most, 24. Colorado 10. We are over here, but in this region, Maine had 1, New Hampshire had 2. We had 9 that fit the definition and were reported, 2 in Rhode Island, 1 in Connecticut, couple in New York, a bunch in Pennsylvania. So, spread all over the place and definitely happening, even though rare. So, because this really, a lot of the attention focused on the fact that there was this new enterovirus D68, it was super common, it was causing a ton of kids to come in wheezing who didn't usually wheeze back in 2014 in Colorado, and right around that time, the AFM reared its head, and so there was a lot of work looking at, are these related? Because no kid, to my knowledge, has definitively had enterovirus D68 in their spinal fluid, although if you look at the CDC reports, there might be 2. But it has been detected in a portion of the patient's other specimens, so respiratory specimens, stool specimens, things like that. And so the data they present is basically, the take-home point is to see that here in this, September timeframe and in the same, these are aligned by date, they're seeing the AFM's peak here was very much following the peak in the enterovirus positive testing. So D60, these are the number that tested positive is in black and negative is in the gray color for the enterovirus D68 at the time. And so you can see they very much parallel one another. This is just additional data from 2014 looking at 3 groups. So this group is the acute flaccid myelitis cases. This is patients at the same institution in Colorado who had other respiratory panels at the same time. And this is a group who had pertussis testing in the ICU during the same time. And what they're showing is that the black is, again, the enterovirus D68 positive. This is enterorhino positive, but did not test positive for the specific D68 subtype. And then these were negative for enterorhino. And you can see that the proportion of cases who had enterovirus D68 was higher in the AFM group than in either of the other groups who had a lot of other enteroviral or non-enteroviral tests, positive tests. So the big question when we see these kids acutely is, what is this and how do we treat it? And in 2014, there was certainly no consensus. While it looks like polio and acts a lot like polio, and there's a suspicion it could be direct viral, we didn't have any of this data. And there's also a lot of inflammatory transverse myelitis that can present with some similarities. And so we've learned some in the last couple of years. And I think most exciting is this new mouse model. So Ken Tyler just published this in the last couple of months, where they, I think I have another slide on it, have taken 5 different strains of enterovirus D68 that were isolated from the 2014 outbreak, and they've been able to induce paralysis in neonatal mice. So if they inoculate them IM, they have the highest frequency of onset of paralysis. If they inoculate intracerebral, intraperitoneal, or intranasal, there's decreasing rates of converting towards to paralysis. The mice who are paralyzed, they can find infectious virus, virion particles, and viral genome in the spinal cords of those mice following the infection. So, I think pretty significant support, although in an animal model. They also find on the pathology of the mice that there's a loss of the motor neurons, and that if they give mouse sera from a mouse that had the disease to a mouse that they're inoculating, it is protective. So again, I think pretty good support that this is an infectious process. So since it's looking more and more like polio, what can we learn from polio? Most of us have never seen polio because it's eradicated and, people have been successfully vaccinated. And so there's some things that I think are interesting and we're seeing in our patients that are polio-like. So I'm not an infectious disease doctor, like many of your speakers today, but what polio, a couple of figures, poliovirus attaching to anterior horn nerve cells, invading those cells, they infect and injure the nerve cells specifically in the anterior horn of the spinal cord. Most of you probably don't think about the spinal cord necessarily on an everyday basis, but this is just a cross-section cartoon that I'm sure you've all seen before, showing where, your sensory nerves typically live here, motor neurons here, and the input gets directed. And then those motor neurons come down and innervate the muscles and tell your muscles when to contract, right? So this is a little bit about, again, what they've learned from polio. Normal muscle, you've got your anterior motor neurons, they come down, they innervate your motor units, your muscle cells, and in acute polio, these neurons can be either killed or injured, but not, depending on the amount of injury, some of your nerves survive. And then this is showing kind of post-polio. So your surviving neurons and your remaining healthy neurons branch out gradually over time, which is, I think, why we're seeing these patients, even though they have poor recovery, they have a very prolonged recovery, much longer than we see with a typical inflammatory myelitis patient. And so they end up building these big motor neuron units, but then over time, they can develop ongoing or progressive weakness. We all lose motor neurons as we age, and so some of the theory is that as you lose those neurons, which were doing a bigger job than they used to do when you were normal, then you end up de-innervated and with the losing muscle fibers and with progressive weakness that can kind of, they recover and then can have decline over time, called post-polio syndrome. So certainly something we're concerned about in our patients, but we don't know how relevant that is in AFM and other, viral causes of this pathology. The other thing that's interesting, particularly with our second case, he had a deltoid injection a couple weeks beforehand, and there's this theory of provocation polio, where an injection or an injury to your muscle or a tonsillectomy around the time or just before you're viremic with poliovirus can potentially create a route of entry for that virus, in theory, to retrograde transport to the spinal cord. We don't really Even in polio, it's sort of a theory and not perfectly established, but I think certainly interesting, and I've been asking all my patients, sort of trying to sense if we're seeing that generally. So just want to say that, polio isn't the only culprit. This isn't totally new. Flaccid weakness due to virus is well known and established, particularly with intervirus 70 and 71. That's been known for some time. And West Nile virus is also a well-known culprit that can cause acute flaccid myelitis in the setting of encephalitis or without. And then you can see there's a whole list of other viruses that can cause myelitis, whether it's really anterior motor neuron specific polio-like myelitis, not necessarily, but these couple, and some of them can. Coxsackie is another one that I thought I had circled. Should be circled. This is another one of the publications that came out of the 2014 outbreak, looking back at cases that had been seen. There had been an enterovirus, I think 71 related reports coming out of California prior to 2014, and this shows just kind of the progression of the disease over time. So the prodromal phase, what do you see clinically with the infection and the symptoms, and then during the progressive neurologic injury, this acute over hours to days presentation of limb weakness, cranial nerve deficits, potentially altered mental status. At the same time, should see mild pleocytosis, maybe an elevated protein. What's been described at the imaging, which we'll look at some pictures too, with this confluent, longitudinally extensive anterior horn predominant gray matter lesion, and what you can see seen on the EMG, which isn't always necessary for the diagnosis, and many patients don't get. And then what is seen in the convalescent phase, the improvements that are seen, the atrophy that we're seeing in the limbs, ongoing weakness in most of the patients, with the resolution of the CSF findings, and either normalization of cord, but also we're seeing they're seeing nerve root enhancement, which I'd argue we've seen in the acute phase, but I think maybe it depends on how acutely they're imaged. And this doesn't talk specifically here about it, but we're seeing some sort of punctate, like the big fluffy lesions become this like little dot in the anterior horn of probably scar, for better lack of a better terminology. So from that same paper, they looked at 4 cohorts, the CDC, which includes kind of everybody, as well as the, this is the Denver Children's, this is, I think, Philly, and Primary Children's Hospital in Utah, looking at the different cases that they had, demographics, what percent had a prodromal illness, and I think for this group most interesting, fever was very common. These are presented in percentages, so we've got somewhere between 45 to 100% reporting fever beforehand, a very large portion with respiratory symptoms, but some also with GI symptoms. And then the spectrum of neurologic presentation is with many, maybe about half at least, with headache, many from 34 to 83, who knows where exactly, stiff neck, often a complaint of pain more often than not, and there were some reported with altered mental status, which I think is important to think about, especially with the ADEM differential and things. This is the same table, another part of the same table showing the neurologic deficits. So some of this is based on definition. If you're following a definition that you have to have a focal limb weakness, of course you've got 100% with weakness, but I think the take-homes are that really it's a very high percentage have some form of limb weakness. In here, a large portion are upper extremity, and classic polio is more often lower extremity, and then the asymmetry is something that stands out about this that can be different from some of our other inflammatory conditions, like a Guillain-Barré usually is very symmetric. Hyporeflexia is characteristic, and then they can have bladder and bowel dysfunction, but it is less common. This is the lab findings. I'm not going to go through all of it, but point being that virus in the CSF, very uncommon to detect. And exactly why that is isn't clear, but if the virus is staying in the nerve cell, it doesn't, and coming kind of retrograde into the spinal cord, it may make sense that it's not necessarily within the spinal fluid. But many do have inflammation, possibly an elevated protein, and we are testing all of the patients. Imaging findings we've talked a bit about. I think one of the interesting things is this nerve root enhancement, which has been a take-home message for me, that it's not usual that we see nerve root enhancement along with a spinal cord lesion. It can happen in ADEM, it can happen in some of these other inflammatory conditions, but the combination is fairly unique. You know, a Guillain-Barré shouldn't have a spinal cord lesion, and a typical TM usually doesn't acutely have this radiculitis seen on MRI. So when we have a suspicion for this disease, we actually image differently and include the lumbar spine, looking at the cauda equina as well as the entire cervical and thoracic cord, so as not to miss this finding. And I'll show you some of the pictures of that too. So again, just a little bit of anatomy, nice cartoon of your spinal cord cross-section, anterior horn here, in the way that this is oriented, so that it is oriented the same as your MRI typically comes out, and showing this is the same patient, this longitudinally extensive T2 bright lesion, along with this kind of H involving both sides. But you can see in his image, it really is anterior predominant. There's a little bit maybe there, but it's more in the anterior horn region. This is the picture of the radiculitis, the lumbar radiculitis. So these nerve roots are usually dark like this, or dark like the spinal cord, and you can see these very bright nerve roots only anteriorly. And then when you look at it on a axial cross-section, again, these are very bright. If you look at a T1 pre, they don't look like this, they look like this dark color. And then, somewhere I thought I had one, but we also are seeing anterior nerve root enhancement on post-contrast imaging, where you can see it up here. These nice little dots of enhancement, which I really haven't seen in any other condition. Hopefully I'll cover that. So differential diagnostic considerations we've talked about a little bit. Idiopathic transverse myelitis, or acute transverse myelitis, which is usually more of an inflammatory condition, can be the first attack of a patient with multiple sclerosis, or NMO, which is neuromyelitis optica. ADEM comes into consideration. Again, ADEM requires encephalopathy as part of the diagnostic criteria. Some of these patients can have some sort of confusion or sleepiness, but it's less common, and certainly someone who's perfectly bright and perfectly with it should not get the diagnosis of ADEM. We should be thinking about other diagnoses. Cord ischemia, given a pretty quick onset of some of these kids' limb weakness, is in the differential, but usually ischemia is faster, over like minutes to hours, whereas the AFM kids progress over more hours to days with their weakness. Other infections, which we looked at on that other slide, systemic manifestations of rheumatologic conditions, or neurologic manifestations of other systemic rheumatologic conditions. There's always something. So, you know, lupus and other strange things can affect the nervous system and present similarly. Guillain-Barré is a big one. And then paraneoplastic and neoplastic, I put it on there, but they really cause a more chronic weakness or chronic presentation. So I don't think too much about those. Just a few points thinking about how do we differentiate between AFM and idiopathic transverse myelitis. So there's definitely overlap, and we consider both when we see these kids, but that lower motor neuron predominance, the proximal weakness, the very flaccid reflexic weakness makes us think more of AFM, whereas idiopathic transverse myelitis really evolves pretty quickly from a lower motor neuron flaccid, low reflex pattern towards an upper motor neuron hyperreflexic pattern pretty quickly over days. AFM shouldn't have sensory involvement in theory, but there definitely is at times, depending on how much inflammation there is and what part of the spinal cord is involved. So we're seeing it, but it's much less prominent than the motor symptoms. The sensory changes are often present with an idiopathic TM, and with the AFM, we're not seeing that classic like band-like sensory change on the torso or things that you can see with the inflammatory transverse myelitis. As I said, AFM can have bladder bowel, but much more common in the other forms of transverse myelitis. The cranial nerve involvement is something that seems fairly unique to AFM as well, so patients can present with ocular movement impairments, they can present with facial paralysis, and we don't usually see that with an idiopathic unless they're having more of a ADEM or initial MS with lots of symptoms kind of a presentation. We've talked a lot about the imaging. The treatment response is really not great in AFM. That's one of the big things, is they just don't turn around with the things we give them. Most of the time they kind of turn around in their own time, and you look at them and they're getting better, but you're not sure that it's because of your treatments, whereas oftentimes you start steroids and within a couple of days you see a clear response with an inflammatory etiology. And then the recovery is slow. It keeps on going is the good thing. I can tell my parents, I know that they're still weak, but I think we're going to still see some more improvement, but it's usually not full improvement, and how much of that improvement leads to functional gains varies. Whereas in your transverse myelitis, they can be left with deficits, but generally the prognosis is better. This is just a little bit on transverse myelitis and how there's two different kinds. We call this complete transverse myelitis, where the whole spinal cord, both sides, is involved. This one looks disturbingly like the gray matter predominance, but you can see there is a bit more in the posterior aspect. And then this is a partial myelitis, and I apologize, it's not the greatest picture with this lighting, but it tends to involve only a part of the spinal cord, be a short segment, and involve just a white matter predominant in part, not this like big central inflamed region. So the workup we usually recommend is, of course, an MRI. And as I said, we do look at their MRI of the brain. If we see classic MS-looking lesions or something, it's going to help us get AFM off of the differential. And they can have lesions, but they don't usually look characteristic for some of our other inflammatory diseases. And then another, just nail it home, like if you're getting an MRI in the ER from clinic, we really want to image the whole spinal cord. So we want their cervical cord, the thoracic cord, and their lumbar spine, looking for that radiculitis with and without contrast. LP, we get routine studies with white cell count and the protein being the most important, looking at oligoclonal bands, IgG index, again, trying to figure out the differential considerations and making sure this is inflammatory. And then other things depend on the differential. We always advocate for saving spinal fluid because we can always go back and add on testing.
Do you want the MRI before the LP?
Usually, although if we can tie the sedation together, that's awesome.
No, because I know in some cases the LP can interfere with the MRI findings, so does it really matter for this?
I think it's highly preferable because post-LP we can really question whether the nerve root enhancement is secondary to the decreased pressure, for sure. And then the part in the red box here is the stuff that's more specific to our suspected AFM patients. So as early as possible, because that viremic phase may be fading out when the neurologic symptoms are coming in. And so I think a lot of our negative testing is because the kids aren't tested early during that viremic phase. And because the timing is just such that it makes it hard to catch. But I think the earlier we test, the better, and that's what I've seen from some meeting data from other hospitals. So we're sending stool, spinal fluid, and nasopharyngeal swabs, doing stuff at the state lab and locally, and then also looking for other viruses, so West Nile, Coxsackie, echoviruses, to look for alternative viral causes besides the enterovirus. And then the lower stuff is stuff that I do with all my new onset neuroinflammatory patients, looking for MS mimics and things like that. So treatment. This is just a descriptive what did people do in 2014 paper, and you see that the vast majority got IVIG. And IVIG is great because it'll cover Guillain-Barré, it will cover infectious, and we give it to our inflammatory myelitis. So it was easy to give IVIG quickly. The plasmapheresis did get used quite a lot, even though there's really no place, it doesn't make a lot of pathophysiologic sense to use plasmapheresis for an infection, but it's also not necessarily harmful. We don't expect it was likely to harm, although you could make the argument that you're taking off potentially protective antibodies that are being developed. We have not seen clinical worsening with either plasmapheresis or steroids, which were used in a large number of patients. So this is the Philly cohort, less in the Colorado cohort, and the Utah cohort, and across the country. Anecdotally, our patient number 2 that I presented, he got worse and worse and worse. And by day 4 or 5, we were like, forget it, we're giving him steroids. And he turned the corner. Like the next day, he started to get stronger. So I think, again, anecdotally, that there is a place after the viremic phase when there's a lot of inflammation and post-inflammatory injury going on, that maybe steroids may have a place, but certainly concerned about giving it early and holding off as much as possible. And it's not clear at this point what the right thing to do is. Some people did use antivirals, as you saw again in our case too, kind of off-label, compassionate use. Not clear if any of them helped. And in retrospect, there was some data suggest that like bacapavir doesn't actually have these anti-intervirus D68 properties. And then this gives you a sense of the portion that needed ventilatory support and had respiratory compromise. And then the last follow-up data is somewhat interesting. So these varied from 9 months, 12 months, short-term 4 months, and what proportion had ongoing deficits. You see it's really high. So this came out after the 2014 outbreak saying, hey, if this is enterovirus D68, fluoxetine in the test tube actually has some anti-enteroviral properties. And it was a very nicely written commentary by Ken Tyler, who then developed the mouse model. And so many of us, including our institution, tried fluoxetine in some of our patients in 2016. It's safe. It's a known side effect profile. We monitored them closely. We did EKGs and over-monitored them most likely. And it's not clear whether it had an effect yet or not. Some of my patients got better, did better than I anticipated, and others not. So I don't know. There is an effort to look at those cases compared to those that weren't treated nationally, and we may have more data in the next year or so there. So he then, of course, now that he has the mouse model, this isn't published, but he presented it in a meeting a couple of weeks ago, so I can show that the preliminary thought is that IVIG is good, and the earlier you give it, the better. Steroids were actually lethal to these mice. Obviously, we're not seeing that in humans, but highly concerning. Fluoxetine didn't seem to make a difference in the mouse. And there's other things that I'm sure they'll be testing, antivirals and other things in the future. So maybe we'll learn more from these little mice. But the big thing was, if they gave IVIG on day 0, so when they were inoculating the mice, they did the best. The further out they gave it, the less effect it had, but even at day 6, so 3 days into weakness, they showed improvement over those who weren't treated with IVIG. So the earlier we can diagnose or even suspect and get our samples and get IVIG into these kids, I don't see a downside, and it may help. It's sort of the take-home message, and I've communicated with him about how much and these things, in some of our conditions, some people give it over 5 days, right? But in reality, kids often tolerate it. We give it over 2 days all the time. They tolerate it fine. In rheumatology, sometimes they give that much over a day. So we're sort of questioning, do we just, in this particular population, give it all quickly? We do know that commercial IVIG has anti-enterovirus D68 antibodies present, so it makes sense that it may help. And I'm sure there are other antibodies, some of these other viruses that some of the kids may have as well. And then I could talk an hour on just rehab and chronic treatment, because that's now where all my patients are falling. And I'm not going to go into too much depth there, but they really need a lot of support, and the families are going through so much with this kind of chronic change in their children. So there's symptomatic treatments. We think about supportive things, respiratory support, physical therapy and occupational therapy are huge. Speech therapy for those who have the oropharyngeal effects, feeding therapy, and this electrical stimulation I was talking about. A lot of the kids like pool therapy, aqua therapy is much easier to tolerate than hours on end with a therapist on land. And then some of them do need some bladder and bowel treatment ongoing, but most of that I see resolve. And then the prognosis is unknown. From what we, if we think this is like polio and expect it to be like polio, the big concern is this post-polio syndrome and long-term, and when might these kids be affected like that. And the take-home of this figure is that there are lots of different pathways that ultimately lead to progressive weakness and decreased motor function. And so I'm worried about where the patients will be many years down the line, and what else we can do for them, the future, potential future patients acutely, and these kids chronically. So, quick summary. We have, I think the biggest take-home points are that we think AFM is likely a direct viral invasion of the anterior nerve cells, like polio. They often have a viral prodrome, and things like neck pain, back pain, these progressive weakness, which can be subtle at first, and little to no sensory involvement, are characteristic. Again, the spectrum, I think, expands beyond the CDC definitions, but not every kid who meets the CDC definition has AFM. And cases should be reported. There's a lot of good information on the CDC website, so I put the link here. And then, again, early workup for higher yield. I think we have to have a low suspicion especially during those fall months, to think about this, to think about doing the workup in any, a little more aggressively. I don't want every kid who has a cold certainly doesn't need a workup, but if there's concerning features, so that we can get early IVIG into the actual cases and hopefully prevent some of the long-term sequelae. Happy to take questions if there are any.